N.K. Soni. I am a senior physician at Yatharth Super Speciality Hospital, Greater Noida, and I am Vice President of Association of Physicians of India. My talk is related to the pharmacological intervention in primary or secondary prevention of atherosclerotic cardiovascular disease that is beyond the control of blood pressure. As Indian patients are more prone to develop all these serious metabolic illnesses early in their age, like diabetes or hypertension or cardiovascular diseases. So, for the treatment of all these metabolic illnesses, lifestyle modification, which includes the diet control along with regular exercise, is the first step. Now, when the patient comes to our clinic and we want to start, or a clinician wants to start any medicine or any pill, usually these patients, they resist of taking of the medicines and say that with lifestyle modification they would like to control their metabolic illnesses, and they plead to the doctor to give some more time for these lifestyle modifications to come into effect. But after a few weeks or after a few months, once they come back, they are in the same position or even worse. So the question is that if we start a pharmacotherapy or a drug therapy early in the course of the disease, can it prevent the development of the complications and can provide a better quality of life to these patients? As we are all aware that hypertension is one of the very important and cause for causing all the mortality and morbidity in large number of the patients, along with dyslipidemia or diabetes or hyperglycemia or even obesity. But hypertension is considered to be the major killer. So once we start the medicine for the control of blood pressure, it gives better protection for even pleiotropic effect also, where it controls the development of atherosclerotic cardiovascular diseases. So there are many studies. The question is that whether evidences are available to support these data. There are two important studies of secondary prevention. One is the ACCORD study. ACCORD trial was done on diabetic hypertensive patients for the control of blood pressure, and it was seen that once we control this blood pressure very rapidly, then it may not produce much better effects. Rather, the moderate control of blood pressure is equally important. Similarly, a second large study of UKPDS in diabetic hypertensive patients revealed that tight control of blood pressure to the tune of around 140 by 80 millimeter of mercury reduces the chances of cardiovascular mortality to the tune of around 24%. So these two studies, they prove that better control of blood pressure or appropriate control of blood pressure in comorbid conditions like diabetes or dyslipidemia is very important for the further delaying the development of complications and providing a better quality of life. Similarly, another trial was done for primary prevention, that in large number of patients, those were followed for 14 years, and it was seen that even if these patients were not hypertensive, were not diabetic, they were not having dyslipidemia or any other complication, even if their blood pressure, which was ranging from 100 millimeter of mercury systolic to 120 millimeter of mercury systolic, it was seen that gradually once the blood pressure increases, the incidence of coronary artery calcium or the diffuse coronary calcium deposition, which was an indicative of atherosclerotic cardiovascular disease, it also increased. So it proves that with a gradual rise of blood pressure, even in a normotensive patients, increases the chances of ASCVD and chances of development of cardiovascular diseases and morbidity. So those drugs which reduce the blood pressure a little bit, can they provide a more results, pleiotropic effects for prevention of atherosclerotic cardiovascular disease? This was the study. And it was seen that in other studies like HOPE trial or EUROPA trial, it was seen that whether use of ramipril or pyrindopryl, they provide the better control of blood pressure, or even in normotensive patients, they reduce the cardiovascular mortality by more than 20%. So, my dear friends, the conclusion of all these trials was that even normotensive patients, they develop ASCVD gradually, which may cause the morbidity and mortality in these patients. The RAS inhibition, reticuloendothelial system, aldosterone system inhibition by ACE inhibitors or ARBs, it provides a better effect for the prevention of ASCVD, whether it is a primary prevention or secondary prevention. Lifestyle modification is the first step which should be followed and which can provide a good quality of life to these patients, and thus these drugs work beyond blood pressure control to give a pleiotropic effect where they can give extra benefits for reduction of the morbidity and mortality for these patients altogether. Thank you very much.